Asthma is not just a clinical challenge, it's a window into respiratory medicine, immunology, and patient-centered care. In this video, we will cover the latest asthma diagnostics, treatment protocols, and high-yield key points. Whether you're preparing for internal medicine exams or clinical rotation, this comprehensive guide is designed for you. Keep in mind that asthma is a chronic inflammatory disease and a reversible airway obstruction. It is characterized by bronchial hyperresponsiveness and airway smooth muscle abnormalities, including smooth muscle hypertrophy that causes narrowing of the airways. Now, there are two types of asthma. One is allergic and the other one is non-allergic. Allergic is the most common type. About 90% of asthmatics have the allergic type, whereas about 10% has non-allergic. Allergic type is also called extrinsic asthma. It is often associated with eczema or rhinitis. Some common triggers include mold, dust mites, pollen, and pet dander. The non-allergic type, also called non-atopic or intrinsic asthma, have the following common triggers: cold or dry air, smoke, exercise, certain viruses, stress, anxiety, perfumes, and even medications such as beta blockers. In patients with asthma, what is the main antigen-presenting cells? They're macrophages. In patients with asthma, what do you think is the main inflammatory cell? Eosinophils. In patients with asthma, what do you think is the most important antibody? It's IgE. What are the three common interleukins associated with asthma? IL-4, IL-5, and IL-13. Keep in mind that these interleukins are high yield since there are specific drugs that can block it. Dupilumab blocks IL-4 and IL-13. Mepolizumab, branalizumab, and reslizumab block IL-5. A 30-year-old male presents to your clinic for his annual checkup. He has a history of childhood asthma. He asked about the classic signs and symptoms of asthma. Which of the following is not a classic sign and symptoms of asthma? Intermittent shortness of breath, cough, sore throat, or wheezing. Keep in mind that the classic signs and symptoms of asthma includes intermittent shortness of breath, cough, and wheezing, but not sore throat. A 40-year-old man presents to your clinic with chronic cough and shortness of breath. A spirometry was completed. Which spirometry finding is related to asthma? An increase in FEV1 of 10% after albuterol administration, an increase in FEV1 of 12% after albuterol administration, or an increase in FEV1 of 20% after albuterol administration? The right answer is B, an increase in FEV1 of 12% after bronchodilators. Spirometry can confirm the presence of reversible airflow obstruction, an airway obstruction that improves with bronchodilators, and an increase in FEV1 from baseline of at least 12% and at least 200 ml confirms the diagnosis of asthma. But remember, it is also not wrong to diagnose asthma clinically without objective data, but for your exams, objective findings, including a PFT or spirometry findings, are a high-yield concept to understand. There should be two spirometry procedures performed in one setting, one without albuterol, then one with albuterol. The bronchodilator response assesses the bronchial hyperresponsiveness of the airway. Pulmonary function test has three components: spirometry, lung volume, and diffusing capacity. In asthma, TLC and DLCO are not as important as spirometry. You may encounter PFT or spirometry on your exams, but remember, spirometry is one of the components of a PFT, but not synonymous with pulmonary function test. Again, keep in mind, an increase in FEV1 from baseline of at least 12% and at least 200 ml confirms the diagnosis of asthma. which indicates that there is a presence of reversible airflow obstruction. A 21-year-old college student presents to your clinic for intermittent shortness of breath and wheezing about 3 to 4 times a week. He reports shortness of breath when he plays soccer or even when he exercises. He also has intermittent, non-productive cough at night. He has seasonal allergies when he was in grade school. He takes no medications. On exam, he is afebrile and hemodynamically stable. He has nasal congestion and clear breath sounds. Which of the following is the most appropriate next step? Do we just monitor, discharge him, and ask him to just follow up with us in a few days? Do we prescribe him intranasal steroid spray, such as Flonase? Do we prescribe him as needed SABA? Or do we prescribe him daily LABA? Although intranasal steroid spray is needed since he does have rhinitis, the most appropriate is to manage his symptoms because he is short of breath. LABA is always the wrong answer on your exam if the patient has asthma, since LABA as monotherapy is not recommended. The correct answer is as needed SABA and instruct the patient to take the inhaler about 10 to 15 minutes before he exercises, since this is probably related to exercise-induced asthma. Now that we have prescribed the patient with as-needed rescue inhaler, such as SABA, what do you think is the recommended diagnostic test to order for this patient? The next diagnostic test is to order spirometry. But what if spirometry is normal and the patient truly has exercise-induced asthma? What do you think is the most appropriate test at that point? Think of challenge testing, such as methacholine challenge test. You're seeing a patient who is 65 years old. He presents to the clinic with a history of intermittent shortness of breath, non-productive cough, and wheezing over the past 10 years. This is mostly exacerbated during a viral infection, and he noticed that his symptoms are more frequent since the COVID pandemic. Despite normal spirometry, normal echocardiogram, and normal chest x-ray, he seeks further management for his recurring symptoms. What do you think is the most appropriate next best step? Would you order a methacholine challenge test, order a fraction of exhaled nitric oxide, or refer him to a cardiologist for stress testing? The patient's symptoms are suggestive of asthma, especially given the recurrent nature and association with viral infections. Keep in mind that in patients over 65 years old, persistent cough post-viral infections is not uncommon. The methacholine challenge testing is valuable in assessing bronchospasms, particularly in patients where spirometry results are normal despite symptoms. This test can aid in confirming the diagnosis of asthma and provide and guide appropriate management. Besides spirometry, another diagnostic testing for asthma that you need to know on your exam is methacholine challenge testing. Methacholine is a cholinergic drug that induces bronchoconstriction, causing an asthmatic attack. A bronchial challenge testing is helpful if the patient presents with typical symptoms related to asthma, but the spirometry is normal. In a methacholine challenge test, we're able to assess the FEV1 over FVC before and after inhaling doses of methacholine. If the result is negative, it is unlikely that the patient has asthma. If there is a decrease in FEV1 and FVC of more than 20%, it is a positive test. A positive methacholine challenge test confirms bronchial hyperreactivity, but it is not enough to confirm an asthma diagnosis. On your exam, you will also encounter fraction of exhaled nitric oxide, also called phenol testing. It quantifies nitric oxide gas in patients' exhaled breath. To collect the sample, the patient breathes slowly and consistently into a mouthpiece linked to a machine for measurement, shown on the right-hand side. Typically, patients with asthma exhibit high phenol levels in their exhaled breath, which normalize following steroid treatment. This high level of phenol is thought to result from eosinophilic inflammation of the airways, prompting the airway epithelial cells to produce nitric oxide. Therefore, phenol serves a potentially valuable marker for monitoring airway inflammation in patients with asthma. A 40-year-old man presents to the clinic with progressive shortness of breath and nocturnal cough over the past year. He is employed as a mechanic in an auto shop. Following a break from work, he reports the absence of these symptoms. Spirometry was performed and results were within normal limits. The patient is uncertain if his symptoms are linked to his work and is contemplating a return to work. What is the most appropriate next step? Would you order spirometry after work or repeat spirometry on his day off? The correct answer is to order spirometry after work exposure to confirm the diagnosis of occupational asthma. Spirometry before and after re-challenge with workspace exposures may confirm a diagnosis of occupational asthma. In occupational asthma, the key clinical indicator is the relationship of the patient's symptoms to work exposures. If the symptoms improve during weekends or time away from work, then consider this diagnosis. Therefore, performing a spirometry before and after workplace exposures may confirm this diagnosis. A 40-year-old male patient presents to the clinic with intermittent nonproductive cough persisting for at least 1 year. He notes that his cough is triggered by exposure to perfumes or weather changes. The patient denies symptoms such as runny nose, postnasal drip, wheezing, or reflux. Despite attempting intranasal steroid spray and oral antihistamine, he experiences no relief. Chest x-ray results are normal, and spirometry reveals a normal FEV1 over FVC ratio. What is the most likely diagnosis? COPD, GERD, or cough variant asthma? The correct answer is cough variant asthma. The patient presents with a chronic cough, which is defined as a cough of at least 3 months. The three most common causes of chronic cough includes cough variant asthma, post-nasal drip, and GERD. In cough variant asthma, cough is the predominant manifestation, without the other typical symptoms of asthma, such as shortness of breath and wheezing. A 40-year-old male patient presents to the clinic with 1 month history of non-productive cough and wheezing. He has a background of intermittent asthma and has not used a rescue inhaler since his mid-20s. The patient is currently taking ibuprofen for chronic back pain since a week ago and is otherwise not on any other medications. On examination, he is hemodynamically stable and afebrile with a BMI of 30. Conjunctival injection and nasal polyps in both nostrils are noted during the head examination, while spirometry wheezing is observed in the lung examination. What is the most appropriate diagnosis? Does the patient have GERD, aspirin exacerbated respiratory disease, or reactive airway dysfunction syndrome? The correct answer is aspirin exacerbated respiratory disease. This disorder involves sensitivity not only to aspirin but also to NSAIDs, such as ibuprofen, which inhibits cyclooxygenase 1. This condition, also known as Samter's triad, is characterized by asthma and rhinosinusitis related to aspirin or NSAIDs. Symptoms include nasal congestion, nasal polyps with chronic rhinosinusitis, and severe late onset asthma. Late onset typically occurring in adolescence or adulthood. The pathophysiology involves overproduction of leukotrienes. The diagnosis is clinical and can be confirmed by history of symptoms exacerbated by aspirin or NSAID use. The major components of management in patients with asthma are selection of initial therapy, and this is based on patient's current asthma severity, assessment of asthma control and risk of exacerbations, and adjusting therapy based on a stepwise approach. Understanding asthma severity will guide us to specific management. This table is high yield to remember. When figuring out which type of inhaler the patient would require, First, let's identify if the patient has intermittent asthma, mild persistent asthma, moderate persistent asthma, or severe persistent asthma. In intermittent asthma, the patient has less than 2 daytime symptoms per week, less than 2 nocturnal awakenings per month, and has no limitations with activity. A patient with mild persistent asthma usually has more than 2 days, but less than 7 days a week of daytime symptoms, 3 to 4 nocturnal awakenings per month, with minor interference with activities. A patient with moderate persistent asthma has daily symptoms with at least 1 nocturnal awakening per week and some limitations with activity. A patient with severe persistent asthma has symptoms several times per day, nocturnal awakenings nightly, and has extreme limitation in activity. Patients with asthma should be prescribed inhaled bronchodilator with rapid onset, such as short-acting beta agonists, SABA, like albuterol or levoalbuterol. Otherwise, deciding which controller therapy in a stable asthmatic patient depends on the severity of the patient's asthma. In patients with intermittent asthma, SABA as needed is recommended. Another strategy is to use a combination inhaler that has a low-dose steroid and LABA, such as formoterol, taken as needed for symptom relief. In mild persistent asthma, which is step 2, the recommended treatment is a low-dose inhaled steroid controller medication. It's been shown that regular use of steroids decreases symptoms and exacerbations and improves quality of life. If the patient is hesitant to start inhaled steroids, leukotriene receptor antagonists such as montelukast is a good option. In moderate persistent asthma, which is step 3, the preferred controller therapy is a combination of low-dose steroid and LABA in a single inhaler. In severe persistent asthma, which is step 4, the preferred controller treatment is at least a medium dose of an inhaled steroid in combination with a LABA. A 40-year-old man presents to the clinic with chronic cough and shortness of breath. He reports experiencing shortness of breath or cough of less than 2 days a week and denies nocturnal awakening. What is the appropriate initial management? The appropriate initial management is as needed SABA or low-dose steroid plus formoterol as needed. These are step 1 therapies. The patient exhibits characteristic of intermittent asthma, defined by the following features: daytime asthma symptoms occurring less than 2 days per week, less than 2 nocturnal awakenings per month, and less than 2 uses of SABA per week. There are no interference with normal activities between exacerbations. Usually, the FEV1 measurements between exacerbations consistently with normal range, and the FEV1-FVC ratio between exacerbations are usually normal. They typically have one or no exacerbations requiring oral glucocorticoids per year. A 40-year-old man presents to the clinic with chronic cough and shortness of breath. He reports experiencing shortness of breath or cough of at least 5 days a week, with 4 nocturnal awakenings in the past month. What is the most appropriate initial management? It's low-dose steroid daily plus SABA as needed. This patient demonstrates characteristic of mild persistent asthma, as indicated by the following: symptoms occurring more than twice daily, approximately 3 to 4 nocturnal awakenings per month, and the use of SABAs relieves symptoms of more than 2 days out of the week, but not daily. A 40-year-old man presents to the clinic with chronic cough and shortness of breath. He reports shortness of breath and cough on a daily basis, with at least one episode of nocturnal awakenings per week. He often requires SABA as needed every single day. What is the most appropriate initial management? The patient has moderate persistent asthma. Remember, in moderate persistent asthma, the patient presents with daily symptoms of asthma, nocturnal awakenings as often as once per week, daily need for rescue inhaler for symptom relief, some limitations in normal activity. A 40-year-old man presents to the clinic with chronic cough and shortness of breath. He reports experiencing shortness of breath and cough every day and at night. He requires daily as-needed rescue inhaler and has stopped going to work due to his symptoms. What is the most appropriate initial management? At least a medium dose of an inhaled steroid in combination with a LABA. The patient has severe persistent asthma. Severe persistent asthma is characterized by the presence of asthma symptoms throughout the day, nocturnal awakening due to asthma nightly, the need for reliever medication several times a day, and extreme activity limitation due to asthma. A 40-year-old man with a history of mild persistent asthma presents with progressive shortness of breath, frequent daytime wheezing, and nocturnal non-productive cough over the past 2 weeks. He started using an inhaler a month ago and reports adherence to the prescribed regimen. On examination, his vital signs are stable, and bilateral wheezing is noted on the lung exam. Which of the following is the most appropriate next step? Add on oral prednisone, add on leukotriene inhibitor, observe the patient's inhaler technique. The correct answer is always to consider poor inhaler technique. It is important to rule this out before adjusting a patient's medication regimen. In a clinical setting, if a patient is using an inhaler, we remind the patient to bring the inhaler and show us how the patient is using it. A 40-year-old man presents to the clinic with another episode of oral thrush. He is currently on albuterol as needed and daily inhaled steroids. Over the past year, he denies any daytime symptoms or nocturnal cough. Which of the following is the most appropriate next step? Perform a step-down management and discontinue inhaled steroids. Perform a step-up management and add a LABA. Add on oral prednisone, or add on leukotriene inhibitor. This patient is doing well, and we should consider stepping down, discontinuing his inhaled steroids, and reassessing his symptoms. It is crucial that the patients are evaluated frequently to determine if stepping down therapy is indicated. This patient is on inhaled steroid and now presents with local side effects of the steroids. An add-on therapy for asthmatic patients includes leukotriene inhibitors. It could be a montelukast or a Zyflo. Montelukast is a leukotriene receptor antagonist, while Zyflo is a leukotriene synthesis inhibitor. Both are oral therapy. They are not inhalers. A 28-year-old male patient with a history of persistent asthma is being evaluated for optimal asthma management. He currently uses an albuterol inhaler as needed and has been prescribed an inhaled corticosteroids for maintenance therapy. Despite compliance with the prescribed medic regimen, he continues to experience occasional nocturnal awakenings due to asthma symptoms and reports exercise-induced bronchial constriction. The physician decides to add a leukotriene receptor antagonist to the patient's treatment plan. Which of the following statements regarding leukotriene inhibitors is incorrect? A. Montelukast may be used as monotherapy for mild persistent asthma. B. Xylitol, another leukotriene inhibitor, is associated with liver function monitoring. C. Leukotriene inhibitors are most effective in providing rapid relief of acute bronchospasms. Or D. Leukotriene inhibitors are recommended as add-on therapy in patients with a history of allergic rhinitis and asthma. Leukotriene inhibitors are not effective in providing rapid relief. Consider a SABA as a rescue inhaler for rapid relief. It is an alternative controller therapy in patients who cannot take steroids in mild persistent asthma or add-on therapy in patients with inadequate symptom control on steroids in patients with at least a moderate persistent asthma. Leukotriene receptor antagonist is also an alternative in patients with allergic rhinitis and asthma. Xylitol, a specific leukotriene receptor antagonist, is associated with liver toxicity. A 42-year-old female presents with severe persistent asthma despite receiving maximal therapy with inhaled steroids and a LABA. She continues to experience frequent exacerbations despite reporting good compliance and appropriate inhaler technique. Chest X-ray results are normal, and lab tests show a normal white blood cell count and an elevated IgE levels. Which medication represent an appropriate add-on therapy for this patient? Montelukast, theophylline, ipratropium bromide, omalizumab, cromolyn sodium. The right answer is omalizumab. Omalizumab is an anti-IgE therapy. This is a medication for patients whose asthma is not controlled on a medium or a high dose steroids, plus LABAs, with high IgE levels. Xolair is the brand name. It's the first biologic agent approved by the FDA for asthma management. It's a humanized monoclonal antibody directed at IgE. It's a subcutaneous route given every 2 to 4 weeks for patients over 12 years old. It is dose dependent on IgE levels and the patient's weight. Because it is associated with anaphylaxis, the medication is administered in a clinic and the patient is required to carry an EpiPen. Anti-eosinophilic therapy such as mepolizumab, benralizumab, and reslizumab can be used as an add-on therapy for patients with severe eosinophilic asthma, but not associated with elevated IgE levels like omalizumab. Keep in mind that before starting mepolizumab, zoster vaccine is recommended since this medication may activate herpes zoster. Dupilumab, also known as Dupixent, inhibits IL-4 and IL-13. It is an add-on therapy for patients with moderate to severe persistent allergic asthma, refractory to traditional medical therapy without elevated IgE levels. Before we end our talk with asthma management, keep in mind that there is a non-pharmacologic therapy for severe asthma, and it's called bronchial thermoplasty. These are ordered in patients who are asthmatics that are not controlled with current standard asthma regimen that we talked about previously. It was approved by the FDA in 2010. A catheter is inserted into the airway and heats up the lining of the lungs, which prevents smooth muscle hypertrophy. It then reduces the airway smooth muscle mass that is responsible for the bronchial constriction, airway responsiveness, and mucus production.
Now let's do some rapid fire questions. What are the two main types of asthma? It's allergic and non-allergic asthma. What is the common type of asthma? Allergic asthma. What type of asthma is triggered by beta blocker or exercise? Non-allergic asthma. What are the three classic signs and symptoms of asthma? Intermittent shortness of breath, chronic cough, and wheezing. What procedure confirms the presence of reversible airflow obstruction? Spirometry. Which spirometry finding is related to asthma? An increase in FEV1 of 12% in at least 200 ml confirms the diagnosis of asthma. What are the three components of a PFT? Spirometry, lung volume, and diffusing capacity. What procedure is recommended if the patient presents with typical symptoms of asthma but normal spirometry? Methacholine challenge testing. What are the three most common causes of chronic cough? Cough variant asthma, post-nasal drip, and GERD. What is Samter's triad? The triad consists of nasal polyps, asthma, and sensitivity to aspirin or other NSAIDs. What is the recommended therapy for intermittent asthma? As needed SABA or as needed low-dose steroid plus LABA. What is the recommended therapy for mild persistent asthma? Low-dose steroid daily plus SABA PRN or low-dose steroid plus SABA PRN or daily leukotriene receptor antagonist and SABA as needed. What is the recommended therapy for moderate persistent asthma? Low-dose inhaled steroids plus LABA. What is the recommended therapy for severe persistent asthma? It's medium-dose steroid plus LABA. Before optimizing therapy for uncontrolled asthma, what are the two questions to ask the patient? Ask about proper inhaler technique and medication compliance. What are the three indications for leukotriene inhibitors? Alternative control therapy in patients who cannot take steroids in mild persistent asthma. It can be an add-on therapy in patients with inadequate symptom control while on steroids in moderate persistent asthma, and an option in patients with allergic rhinitis with asthma. Which leukotriene receptor antagonist has liver toxicity? Xylitone. Which add-on therapy is recommended in patients with uncontrolled asthma despite inhaled steroids plus LABA with a high IgE level? Omalizumab. Which anti-eosinophilic therapy is known to activate herpes zoster? Mepolizumab. Thank you for listening. Asthma is a high-yield topic in internal medicine, and I hope you have a better understanding of what asthma is. Be sure to visit my Instagram and YouTube accounts where I share high-yield content daily to assist you in preparing for your internal medicine shelf exam, IM rotation, and USMLE Step 2 exam. Take care and good luck.